we've developed what I'd like to think is a good relationship with our colleagues in India at Ganga Hospital, who've volunteered to give us this lecture series. Today we have Dr. Tuhin, one of the consultant anesthesiologists at Ganga Hospital. And to introduce him, I would like to ask Dr. Bala, who has been instrumental throughout this program, to say a few words about today's presenter and any additional words that he would like. Dr. Bala, please.
Thank you very much, Arthur. And today we have the pleasure of having Dr. Tuhin Mistry to share his thoughts with us. Tuhin, after completing his post-graduation in anesthesia, was highly focused on regional anesthesia. He did a one-year postdoctoral fellowship in nerve block and pain management affiliated to Dr. MGR Medical University at Ganga Hospital. And he showed his capabilities in the exit exam. He did remarkably well. And then he went on to do a palliative pain fellowship in All India Institute of Medical Science, New Delhi, and returned back with more knowledge and more grit. And he's a very keen teacher, a person who wants to publish a lot. And the recent one has been cited a lot in the British Journal of Anesthesia, the CAPS approach to popliteal plexus of the sciatic, which is going to also possibly demonstrate to you and show you during the course of his talk. And he, as I said, he eats, sleeps, drinks regional anesthesia. A very keen enthusiast of regional anesthesia. We find him a great asset to our institution in taking RA forward and in teaching young students. With this, I have great pleasure in welcoming Dr. Tuhin Mistry, basically from Calcutta, settled in Coimbatore, to deliver his talk today and share his insights into a very interesting topic. Over to Tuhin.
Thank you, sir. Thank you so much for kind words. Good evening from India, and greetings from the Department of Anesthesiology and Perioperative Care, Ganga Medical Center, Coimbatore, India. So, without wasting time, let's start with the today's topic, that is the sciatic nerve. So let me share the screen. Yeah, is my screen visible?
Yes, your screen is just about to start sharing. I've just made you co-host, so I think you should be able. Yes, I think we can see your slides now.
Yeah. So these are my declaration. There is no conflict of interest. The illustrations and schematics are mostly my personal drawing, and appropriate patients and volunteer consent have been obtained. I will be focusing on the indications, contraindications, the various approaches, the anatomy, microanatomy, and sonoanatomy, and various techniques described in the literature, and the complications related to the sciatic nerve block. So the sciatic nerve block is indicated for lower limb surgeries, including the knee and ankle and foot surgeries. It often needs the lumbar plexus block or femoral or saphenous nerve block to provide complete anesthesia or analgesia according to the surgical area. It is absolutely contraindicated in case of patient's refusal or where there is presence of infection at the site of needle entry point. Rest all are relative contraindications like systemic sepsis, patients on anticoagulants, patients with coagulopathy, or any presence of pre-existing neuropathy. In such cases, check the risk-benefit ratio, discuss with the patient and relatives, document everything, and before proceeding for the sciatic nerve block. So let's start with the functional anatomy of the sciatic nerve. In the previous class, Dr. Vipin Goel has discussed in detail about the sacral plexus. The sciatic nerve is the largest branch of the sacral plexus, and it is around 2 centimeter in diameter and 45 centimeter in length. It exits the pelvis through the greater sciatic notch below the piriformis muscle and travels in the posterior compartment of the thigh. It gives off it descends between the greater trochanter and the ischial tuberosity, and it gives off numerous articular branches to the hip joint and knee joint, and numerous muscular branches to the semitendinous long head of biceps femoris, adductor magnus, that is ischial head of adductor magnus, semimembranosus, and the branch to the short head of biceps femoris comes from the common peroneal nerve. And at the level of the lower third of the femur, it diverges into tibial and the common peroneal nerve. The tibial nerve supplies the major osteotome and the myotome of the leg below the knee joint. So before going into the different block techniques, it is very important to know the dermatome, osteotome, and the myotome of the surgical area to provide incision congruent regional anesthesia, but specific for the procedure. So as you can see, the leg below the knee is mostly supplied by the sciatic nerve except on the medial side, and this is the dermatome, and on the right side osteotome, which is mostly by the sciatic nerve below the knee joint. And if you look at the posterior part of the thigh, the major dermatomal supply is from the posterior femoral cutaneous nerve. So to note this, that the sciatic nerve does not supply the cutaneous innervation in the posterior compartment of the thigh. You need to block the posterior femoral cutaneous nerve, such as in case of application of tourniquet or any surgery over this area to provide complete analgesia. The below knee, as I already mentioned, this lateral part is supplied by the lateral and posterior is supplied by the sciatic, and medially by the saphenous nerve. So, like other blocks, it needs informed consent, IV access monitoring, last kit, aseptic technique before proceeding for the block. And in the proximal sciatic block, patient might need sedation also. 50 to 150 millimeter needle, depending on the build of the patient and the area where you are blocking the sciatic nerve. You need various sizes of needle. If you are using PNS, the initial current would be 1.52 to 1.5 milliamps and pulse width 0.1 to 0.2 milliseconds, and the frequency would be 1 hertz. And for ultrasound guided sciatic nerve block, the linear or curvilinear transducer, depending on the build of the patient or the area where you are doing the block. Local anesthetic, again, depending on your practice and the availability at your setup, you can use ligdocaine, levobupivacaine, the ropivacaine with or without adjuvant. Here at Ganga Hospital, we use dexamethasone as an adjuvant. Concentration depends on the indication. If you are using it for the anesthesia purpose, that is for surgical anesthesia, better to go for the higher concentration like 0.5% bupivacaine or 0.75% ropivacaine. And for analgesia purpose, 0.2% to 0.1% ropivacaine and 0.25% bupivacaine is fine. The volume would be 20 to 30 mils. So coming to the responses. The twitches of the foot toes are acceptable. The inversion response is the most favored response among these 4 responses. Why so? Because, and eversion is the least preferred response. Because if you look at the muscles causing the inversion, that is tibialis anterior and the tibialis posterior. Tibialis anterior is supplied by the deep peroneal nerve, and the tibialis posterior is by the tibial nerve. So the inversion response indicates the central location of the needle tip. That is, whenever you are doing a PNS guided popliteal sciatic nerve block and you are getting an inversion response, that means that your needle tip is located between the two components. So it is a very good spot, the sweet spot for this sciatic nerve block. So this might increase the chance of success and and produce a quicker onset or longer duration of block. Similarly, if you look at the muscles producing eversion, that is peroneus longus, peroneus brevis, they are supplied by superficial nerve. So that is from the common peroneal nerve. So that's why the eversion response is least preferred. So the inversion is always most preferred, and then the plantar flexion, dorsiflexion, and then the least one is the eversion. So if suppose if the below knee cast is POP cast is applied, in those cases, the eversion and the inversion response will not be visible. So in those cases, the toe flexion, dorsiflexion or plantar flexion is acceptable responses. Then coming to the various approaches of sciatic nerve block, there are different approaches are described in the literature. I will describe one approach in each position. I will try not to make you confused because there are a lot of approaches, around 15-20 approaches are described, and PNS guided approaches and different ultrasound guided approaches, lot of approaches are there. So better to focus on one approach in one position. And I will humbly request you all to learn and master in one approach which you are comfortable with. So proximal sciatic nerve block, there is posterior approach. This posterior, lateral and anterior, whatever you are seeing, these are according to the needle direction. After entering into the subcutaneous plane, the direction of the posterior approach is needle is going posterior to anterior. Lateral is needle is going lateral to medial, and anterior is needle is going anterior to posterior, not according to the position of the patient. Okay, so posterior approach, already Dr. Vipin Goyal in his last class has described this Lobert's approach and Winnie's modification of Lobert's. The lateral approach, Gardini's approach, anterior, Beck's and modification, and subgluteal approach I will discuss. So according to the proximal side position, proximal sciatic nerve block there is subgluteal approach. We have the popliteal fossa block. This is in prone position. In the supine position, we have anterior approach, and in supine position from the lateral side we have proximal lateral, and I will discuss about the caps block also. So coming to the subgluteal approach, subgluteal space is a anatomical space anterior to the gluteus maximus muscle. It is a potential space between the gluteus maximus and the quadratus femoris muscle. The sciatic nerve here appear on the ultrasound image as the hyperechoic oval-shaped structure. The other structures in this space are posterior cutaneous nerve of the thigh, inferior gluteal artery and nerve, the nerve to long head of biceps femoris, vasa vasorum of the sciatic nerve, and the anterior branch of the circumflex femoral artery. And on the medial side, there is ischial tuberosity and the origin of the biceps, semimembranosus and the semitendinosus. And on the lateral side, there is greater trochanter of the femur. Why to choose the subgluteal space? Because the bony landmarks are very easy to palpate, and it is relatively superficial as compared to the transgluteal approach, that is Labart's and Winnie's modification. So very simple landmark, that is in ischial tuberosity medially and the greater trochanter laterally. These two you have to identify, and you have to identify the midpoint of this line joining two important bony landmarks. So it can be performed in lateral position, it can be performed in prone or semi-prone position, and it can be performed in supine or lithotomy position, which was described by Dr. Prithviraj, and it is popularly known as Raj supine approach, or it is also known as GTIT approach. One thing is important here in lithotomy approach, because you need some support or human assistance. That is, somebody has to hold the leg in lithotomy position. So this leg can be moved while you are stimulating the nerve. Your needle can get displaced. So be careful while performing this approach in the supine position. So here you are seeing one video, and I'm performing the GTIT approach in lateral position. The needle entry point was exactly at the midpoint between the GT and the IT, and the needle you have to enter absolutely perpendicular to the all plane. And after about 5 to 7 centimeter, 80 millimeter or 10 centimeter needle is chosen for this approach, and you will get the desired response, that is plantar flexion or eversion or dorsiflexion. At this proximal level, any response is acceptable. Then if you are not able to palpate these two landmarks are usually palpable even in obese patients also. But if you are not able to palpate these two landmarks, another simple technique was described by Dr. Franco, that is popularly known as the Franco's 10 centimeter approach. So you just have to identify the intergluteal cleft by simple visual inspection, and a point is you have to mark 10 centimeter lateral to the intergluteal midpoint of the intergluteal cleft. This 10 centimeter lateral to the intergluteal cleft at this level, that is the mid-gluteal level, or the sciatic nerve. The sciatic nerve runs 10 centimeter lateral to the midline. So it is the position of the sciatic nerve is almost constant at this level as well as at the subgluteal level. So anywhere it can be blocked between the mid-gluteal as well as the subgluteal level. Just 10 centimeter lateral to it, the needle entry will be perpendicular to the skin. Coming to the ultrasound guided subgluteal approach, the probe is placed between the GT on the lateral side and the ischial tuberosity on the medial side. The needle can be performed in out of plane or in plane technique, and from lateral to medial side, and the drug is deposited around the sciatic nerve. Be careful about the inferior gluteal vessel not to puncture the artery. So here I'm doing the ultrasound guided subgluteal sciatic nerve block in out of plane technique. As you can see, the probe is placed between the GT and the IT, and the needle entering through the out of plane approach. Here you can see the hyperechoic oval shaped sciatic nerve and the gluteus maximus muscle above and the quadratus femoris muscle below. And here is the local anesthetic. You can see just lateral to the sciatic nerve. It is the sciatic nerve is more close to the ischial tuberosity at this level. So coming to the anterior approach. Anterior approach, traditionally we have been taught about the Bake's approach during our post-graduation. So Beck's approach, the problem with the Beck's approach is it usually hits the lesser trochanter of the femur. Originally, this landmark was described as the line joining the pubic tubercle and the anterior superior left spine, and the second line parallel to the first line is drawn from the greater trochanter. The first line is divided into three parts, and the perpendicular is drawn on the second line, and this will be the needle entry point. But the problem with this is most of the time it hits the lesser trochanter, and there is also chances of vascular injury. As you can see here, it is very close to the femoral vessels. So we don't practice the Beck's approach anymore. So I will not recommend this to practice this approach. The another one is this Aisun Uj et al. They did one cadaveric study, feasibility study of another modification of Beck's approach. The technique they have described, it appeared anatomically safe with a lower risk of damage to the middle neurovascular structures. And they also commented that femoral nerve also can be blocked simultaneously to obtain a larger area of anesthesia for the lower limb. So in this technique, the needle entry point, that is the needle entry point for the anterior approach of sciatic nerve, proximal sciatic nerve, will be 4 to 5 centimeter distal to the femoral crease and 1 to 2 centimeter lateral to the femoral artery. This was the cadaveric study done by the Uj et al. In 2010. The technique, the landmark was described by Choube in 1999. What is the landmark? The pubic tubercle and the anterior superior iliac spine are joined together. That is the inguinal ligament. And at the midpoint of it, one perpendicular is drawn of around 8 centimeter. This red cross is the needle entry point. See, it is away from the femoral artery. Chances of vascular puncture is less. And also, while withdrawing the needle, we can also block the femoral nerve as it is lateral to the femoral nerve. This needle entry point is lateral to the femoral nerve. So it is also described as the 2-in-1 block. So in single puncture, we can block the sciatic nerve and the femoral nerve also. So this is the technique from 8 centimeter distal to the inguinal ligament. Here you can see I'm entering 8 centimeter perpendicular to this area. Needle entry point is 8 centimeter distal to the inguinal midpoint of the inguinal ligament. Coming to the ultrasound guided anterior sciatic nerve block, here the is either the leg is positioned in neutral or slightly extended. The ultrasound probe is placed on the anteromedial thigh and the bony structure is first identified, that is the shaft of femur or the lesser trochanter. And medial to that, one vascular structure is the femoral artery or the profunda femoris artery can be identified, and the muscular structure from above downward will be medially adductor longus muscle, adductor brevis muscle, and adductor magnus muscle. In between the adductor magnus muscle and the biceps femoris or the semitendinosus muscle, the sciatic nerve will be visible as an oval structure. So here, either lateral to medial or medial to lateral or out of plane technique we can use, and we can deposit the drug next to the sciatic nerve. Here it is a deeper block and advanced level block, and 10 to 15 centimeter needle is required for this block. And also it is suggested to use the neurostimulation to stimulate the sciatic nerve here, because sciatic nerve is highly anisotropic and it is sometimes confusing with the biceps femoris and semitendinosus tendon. So better to use neurostimulation along with the ultrasound while doing this block. So here you can see the hyperechoic bony shadow, that is the femur, the femoral artery and vein, and superficial femoral artery and vein, and then the sciatic. Here you can see the hyperechoic sciatic nerve, and the LA is deposited. Either the needle entry was either in plane from lateral to medial, medial to lateral, or in out of plane, and the drug was deposited next to sciatic nerve. After depositing the LA, the paraneural sheath or the epimysium of the muscle will be delineated, and the sciatic nerve will become more prominent here. And following the performance of the sciatic nerve, it is always advisable to scan in the longitudinal view also. So after performing the block, if you scan longitudinally, sciatic nerve will appear as a longitudinal cable-like structure, and the local anesthetic will be seen on both sides, the anterior and the posterior side of the sciatic nerve inside the paraneural compartment. And in this longitudinal view also, you can use this view to perform the sciatic nerve either from cephalad to caudal or in caudal to cephalad direction of needle entry. This also can be used for blocking the sciatic nerve. But be careful about the blood vessel, and don't forget to put on Doppler before inserting your needle while doing in the longitudinal approach. Then coming to the proximal lateral approach, it is performed in the supine position. It is popularly known as the Gardini subtrochanteric approach. So what is this approach? The greater trochanter is identified, and a line 2 centimeter posterior and 4 centimeter caudal from the greater trochanter is identified. That will be the needle entry point. The needle is inserted perpendicular to the skin, and then look for the sciatic nerve. The needle is entering from the lateral side, so usually we will get either eversion or dorsiflexion because it is expected to stimulate the common peroneal component. So that's why we'll get either dorsiflexion, or at proximal level, the common peroneal response is acceptable. So we will accept this response and inject the drug here. If you are hitting the femur with this approach, then you just have to withdraw the needle and go a little bit posteriorly, that is 20 to 30 degree posteriorly. That's all. Similarly, an ultrasound guided approach of proximal lateral sciatic was described. That is, the probe position is 2 to 3 centimeter distal or caudal to the greater trochanter, and you will find the greater trochanter or the shaft of femur, and then gluteus maximus muscle, and below the gluteus maximus you will find the sciatic nerve here. So out of plane you can block this nerve here. So it is similar to the Gardini's approach. So coming to the distal sciatic nerve block or popliteal fossa block. Popliteal fossa block is indicated, is widely practiced in ankle surgeries and foot surgeries, along with the saphenous or the femoral nerve block. The popliteal fossa is bounded on the medial side by the semimembranosus and semitendinosus muscles, and on the lateral side, the biceps femoris muscle. The sciatic nerve at this level diverges into the common peroneal and the tibial nerve. This divergence can occur from the origin and at any level proximal to the popliteal crease. From the origin itself, it can run as a separate nerve, and they are functionally not attached. They are inside the common paraneural sheath. This white color structure you can see, this is the paraneural sheath. These two components are housed inside the paraneural sheath. So this is a connective tissue layer. So at the popliteal region, there are two compartments. One is a sub-epimysial perineural compartment that is in between the paraneural sheath and the epineurium of the muscle. and another is the subparaneural compartment that is deep to the paraneural, this white color paraneural sheath. So our area of interest or the sweet spot or the destination of local anesthetic is inside this paraneural sheath. So while injecting, we should pierce the paraneural sheath and inject the drug inside. There is another update in the anatomy, microanatomy, is this tibial nerve and common peroneal nerve. They are separated by a septum known as Koku septum or Compton-Kuvelheier septum. This is the another fibrous connective tissue connecting the anterior and the posterior part of the paraneural sheath. This septum might cause hindrance in spread of local anesthetics from one compartment to another. So just ensure while doing the sciatic nerve block at the popliteal fossa, just ensure that the drug reaches to around the both nerve and ensure the circumferential spread. So like the proximal sciatic nerve block, the distal sciatic nerve or popliteal fossa block can also be divided into posterior approach and lateral approach with conventional technique by supine or Raj technique and the blocker steptome, various approaches like the proximal sciatic nerve block. So coming to the posterior approach, it can be performed again in prone position, lateral position, or supine or lithotomy position. So in the biceps tendon on the lateral side and the semimembranous or semitendinous tendon on the medial side are identified. One thing to be noted here are these two tendons, it never meets. It never meets here, not close to this popliteal fossa. So they are separated. This is also known as the intertendinous approach. The point of needle entry will be either in between these two midpoint of these two tendons, almost 5 to 7 centimeter above the popliteal crease, or actually sciatic nerve passes or lies more close to the biceps femoris tendon, that is more laterally. So another needle entry point was described as 5 centimeter above the popliteal crease and 1 centimeter lateral to this point. So it, as you can see, it can be performed in prone lateral or even in supine position. But in supine position, again, somebody has to hold the leg. So here you can see performing the popliteal sciatic nerve block PNS guided in lateral position. The needle entry point is close to the biceps femoris tendon. Again, here, this is the distal approach. So here, only the plantar flexion or the inversion are desirable. So first start with the 1.5 or 1 milliamps and then gradually decrease it to 0.4. And with 1 ml of local anesthetic injection, it will disappear. Twitches will disappear. This is known as the positive Raj sign. Now, coming to the ultrasound guided technique, we start scanning from the popliteal crease, and from popliteal crease, we go cephalad, that is upward. So while scanning, we have to identify the hyperechoic bony structure, that is the femur, the vascular structure, that is popliteal artery and the popliteal vein, and on the slightly lateral to the popliteal artery, we will get the tibial and the common peroneal nerve, that is the sciatic nerve. So the ideal point for injection at the popliteal level would be the point of divergence, at the point of divergence or below it, to avoid the injury to the sciatic nerve, because the paraneural sheath is more delineated at the level of divergence or below it. So here I'm doing popliteal fossa block in position. The needle entry is from lateral to medial side. As you can see, I'm coming from the lateral side. So this is the common peroneal nerve, which is getting separated from the paraneural sheath. And if you can see, there is uneven distribution of the local anesthetic. The local anesthetic is not, there is no circumferential distribution around the tibial. So in that case, it probably because of the presence of that cocu septum, because it is visible only with high-end ultrasound. So in that case, you have to go towards the opposite side and deposit the drug to make sure that there is halo around both the nerve. Then before doing the popliteal sciatic block or any approaches, always scan cephalad in caudal direction to get an idea about the distribution of the nerve. Here you can see the two component, that is, here it is a single component, that is the sciatic nerve, and now it is getting divided with a separate paraneural sheath. And there is a clear gap in between these two. That gap, usually we target that gap for local anesthetic deposition to avoid the neural injury. So this is the scan on the right side. What you are seeing is the scan after the block. So you can see the clear halo around the common peroneal and the tibial nerve, which is popularly known as the donut sign, and we call it as a Medu Vada sign. So coming to the distal lateral approach, it is popularly known as Francos supine approach. Here we are targeting the sciatic nerve from the lateral side in a supine position. The patient lies in supine position, the knee joint is extended and in neutral position or slightly fixed. The first superior border of the patella is identified, then vertical line towards then vertical line is drawn on the lateral aspect, and the groove between the vastus lateralis and biceps femoris is palpated. This groove is visible in lean and thin patients and pediatric patients or muscular adult. This groove is visible. So on this groove, on this line, one line is drawn in this groove and another line is from the superior border of the patella. The intersection of this point is noted, and 0.7 to 8 centimeter proximal to this point is chosen for the needle entry. The direction of the needle entry will be perpendicular to the skin. First, you might hit the femur. In that case, just withdraw the needle and go 30 degree posterior. And then first you might hit the common peroneal nerve. So you will get the response, common peroneal response, that is the eversion or the dorsiflexion. So in that case, just withdraw and go posterior and medially, more posterior and medially. So elicit the tibial response. So here you can see this is the plantar flexion. At this point, you can aspirate and inject. Now coming to the ultrasound guided popliteal fossa block. So according to the patient's position, it can be performed in prone position, so posterior needle entry, lateral position or supine position through posterior needle entry, and supine in posterior, lateral or medial. Needling technique or direction: in plane, out of plane, posterior to anterior direction, lateral to medial or medial to lateral. And spatial or modified position were also described to overcome the technical issues with the other techniques, that is reverse in position, gap supine, and figure of 4. But the prone position or the lateral position, in fact, where you are changing the patient's position, it can be associated, it can be harmful for the patient. In case of spine injury, morbidity, hemodynamic instability, pregnant lady, as well as those on the mechanical ventilation. Hence, the popliteal sciatic nerve block in supine position is an attractive alternative to provide the greater patient comfort while performing the procedure. It is comfortable for the performer also. if you can see here, the technical issues, the supine technique was chosen because of the was studied because of the difficulties with the prone and the lateral position. But there are some technical issues with this supine position also. The surface becomes uneven because of the flexion at the knee, and the optimization of image become difficult, and the stabilization of probe becomes difficult, and the final image acquisition, then needling and manipulation is tiresome for the operator, and it also requires assistance. So if you observe carefully in all those described ultrasound guided supine approaches, lifting the leg or flexion at the hip and knee joint is required. The limb movement might result in pain or misalignment of the non-stabilized fracture segments, especially in case of trauma patients. Hence, we need a technique to perform the sciatic nerve block in neutral position, neutral limb position. So the possible solution could be the CAPS block. CAPS full form is crosswise approach to popliteal sciatic block. Recently, we have described the CAPS block as a technical note and as a case series in these two journals. I would like to request you all to read about this block if you have not already read. So the CAPS stand for crosswise approach to popliteal sciatic. Crosswise means the across or transverse. So the ultrasound beam, when we place the transducer on the lateral aspect of the distal leg, distal thigh, the ultrasound beam perpendicular to the sciatic nerve, generating a transverse cross-sectional image. It visualizes the sciatic nerve in the short axis medial to the biceps femoris muscle. So if you can see the transverse section at the distal the sciatic nerve travels medial to the both heads of biceps femoris. This left one is the before divergence and the right one is after divergence. Here, this is we can catch the sciatic nerve just below the just medial to the biceps femoris muscle. So the probe position will be lateral to the distal thigh, and I use linear transducer for pediatric and the thin-built patient. If you keep the probe here, you will be able to visualize the biceps femoris muscle with a linear probe, and just below the muscle, you will find the sciatic nerve and the popliteal vessels. Popliteal vessels may or may not appear in the image depending on the level of scanning. And with the curvilinear transducer, which you might need in muscular adult or obese patients, so here you will find the femur, the vastus lateralis muscle, biceps femoris, semimembranosus and semitendinosus on the posterior side, and the sciatic nerve with the popliteal vessels. So the success of CAPS block depends on the scanning technique and the appropriate positioning of the transducer. So first, the transducer is positioned on the distal thigh just above the popliteal crease and at the level of the superior border of the patella, either over the groove between the vastus lateralis and biceps femoris, or the below the vastus lateralis muscle. There is the intermuscular groove you can see. This is the first position of the transducer, and then you have to scan cephalad. So this will be the final position to get a view of the sciatic nerve. So this is a scanning technique. As you can see, first I have kept the probe over the distal thigh just proximal to the popliteal crease, and then slowly I am going up. So going cephalad. So you can see the two divisions here and joining to form the sciatic nerve along with the popliteal vessels you can see here. So on the left side, you are seeing the out-of-plane approach for the CAPS block. The common sciatic nerve is visible here. And on the right side, you are seeing the in-plane technique. Same block. So just pierce the paraneural sheath and deposit the local anesthetic to around the sciatic nerve. So just make sure that your local anesthetic encircles the sciatic nerve well to increase the success rate. So coming to the complications of the sciatic nerve block, could be nerve injury because of direct needle trauma or because of the local anesthetic injection, local anesthetic chemical neurotoxicity, etc. Infection can happen while you are using catheter for the continuous popliteal fossa block or proximal sciatic nerve block. So use absolute aseptic, take absolute aseptic precautions in those cases. The delayed recovery could be because of using higher concentration or use of adjuvants like dexamethasone. It can prolong the duration. So in those cases, you just need assurance. The pressure necrosis of the heel to insensate foot, this can happen if you're using continuous catheter technique. Just keep one foam or a pillow, something soft pad below the heel to prevent this. And the delayed detection of the compartment syndrome can happen if you are using higher concentration or you are doing the motor block. So that's why in all post-op analgesia, in all cases for post-op analgesia, we use 0.1 to 0.2% ropivacaine or 0.25% bupivacaine without adrenaline or without any adjuvant in case of post-op analgesia to avoid this detection of the compartment syndrome. So to conclude, the few tips I want to share, that is the response less than 0.2 milliamps indicates the intraneural needle tip. So avoid injection of local anesthetic in such cases. Always target the subparaneural injection, that is the sweet spot for early onset and effective blockade. The first sign of block onset will be the patient will be unable to wiggle the toes. On the right leg, you can see the wiggling of toe, but the left side, patient will be unable. And I would like to request you all to try the CAPS block and give your valuable feedback. Thank you. Thank you, Global Anesthesia Department and Zambia Regional Anesthesia Society for giving me this opportunity. Thanks.
Thank you very much, Dr. Tuhin. That was quite a concise and clear presentation. We thank you for that presentation. With that, I think I'd like to open the floor to any questions that we have for Dr. Tuhin. I'd also ask Dr. Tuhin to maybe type his email, if he doesn't mind, on the chat, so that if there are any members who would like to get in touch with him, they could do so personally. Yeah, so any questions that we have from our audience today?
There is if anybody wants, there is a detailed description of the CAPS block on my YouTube channel. So you can watch that video.
So there are two questions from Anesthesia TV. One from Dr. Kuma. He says, what transducer is used for posterior and anterior approach?
For anterior approach, curvilinear probe is used. And for posterior approach, it depends. If you are using it on a pediatric patient, linear probe is enough. Even for anterior approach, linear probe is enough. But if it is for adult patient or obese patient, obviously for proximal approaches, curvilinear probe.
Okay, another question from Dr. Babesh, also from Anesthesia TV. How to assess depth in landmark guided technique, IT approach or popliteal fossa block? Is there any law? I guess he's asking generally about judging the depth.
Usually, the sciatic nerve is quite superficial as compared to the transgluteal approach or midgluteal approach. So usually, you will in a normal build patient. Usually, we get it around 5 to 7 centimeter. Usually, we get the response, and the landmark is also quite constant because the sciatic nerve travels in the midpoint or little bit medial towards little bit towards the ischial tuberosity. So, if the patient is not obese or muscular, then usually we get it in around within 10 centimeter. Usually we get. There is no bony landmark to assess the depth. Like in other approaches, we are either hitting the femur or other bony landmarks. Yeah, loss of resistance you can feel. You can, while puncturing the paraneural sheath, if you are using a blunt tip needle, we always feel the loss of resistance. But it's a bit. I would better suggest that you should always use the at least PNS, peripheral nerve stimulator, to stimulate and identify, locate the nerve.
Okay, thanks very much, Dr. Tuhin. Any more questions? Or there's another question from, let me just get to it, again from Anesthesia TV.
For TCare, the preferred site for sciatic nerve. Yes. For TCare, if you are using, first of all, we are not using sciatic nerve block for TCare because we, on the day of surgery itself, we are mobilizing the patients. So we are using motor sparing block, that is dual subsarterial block. You can search on the Google. We had published that dual subsarterial block for the TCare. And the second point is, if you want to provide analgesia with sciatic nerve block for TCare, I will always advise to go for the higher approaches, that is proximal approaches, and make sure that the posterior cutaneous nerve of thigh is blocked also because of the tourniquet pain. And so up to subgluteal level, the approaches can block the this posterior cutaneous nerve of thigh, but below that, it is not blocked. You have to block either with the infiltration separately. So better to go for higher approaches like Mansoor parasacral sciatic nerve block or sacral plexus block, then mid-gluteal approach, Francos approach, or subgluteal approach. All these approaches, they can block the posterior cutaneous nerve of thigh and the sciatic nerve also before giving the branches to all the muscles around the knee. But we provide motor sparing analgesia, so we don't use sciatic nerve block for the TCare.
Okay, it seems like you anticipated my question. I was going to ask guidance on lower versus higher approach. Okay, any other questions from anyone? Please feel free to ask as we conclude today's discussion. For those who may be watching through Anesthesia TV, Dr. Tuhin has given us his email address, tm.tuhin 87@gmail.com. Get in touch if you need to. Any other questions? Okay, it seems that we've exhausted today's questions. I look at my time, it's exactly 1 hour from the time we started. With that, I would like to thank today's presenter, who is Dr. Tuhin. He's just shared actually right now his YouTube channel. Please go there and subscribe if you can. And I'm sure there's content related to regional anesthesia there. So Dr. Tuhin, once again, and our friends from Ganga, we would like to thank you. We look forward to working with you and look forward to more presentations. And we'll be with you again in about 2 weeks.
Thank you, Dr. Arthur. Thank you.
Everyone who's tuning in from Anesthesia TV, our friends from the African Society of Regional Anesthesia and back home here in Zambia, thank you for joining. Any last words, Dr. Tuhin?
Yeah, thank you, Dr. Arthur, for giving me this opportunity. It's my pleasure and an honor to be with you guys and present here. Thank you so much. All the best.
Thank you to you. Thank you. And Dr. Bala as well, thank you. We'll see you again, and we'll see everyone again in 2 weeks. Thank you, and
okay.
Good morning, good evening, and good afternoon, depending on where you are.
Good morning. Good.
Thank you.
Bye-bye.